too badly impacted by the snow. So we're very happy that you're able to join us this afternoon, and very delighted to have such a expert presenter as Dr. Dana Smetherman. Dr. Smetherman comes to us from Oxner, the Oxner Medical Institution in New Orleans. She has been there since 1996, and as well as being an expert breast imager and is their section head for breast imaging, she also holds the titles of Vice Chair for Quality and Operations and Vice Chair for Clinical Affairs. So she's got a lot of experience in payment policy. She represents the ACR at CPT and at the RUC, and is extremely familiar with tomosynthesis as a technique and how that technique can appropriately fit into our armamentarium of breast care. So with that, I will turn it over to Dr. Smetherman. Thank you.
Well, thank you all for taking time out of your schedules to join us this afternoon. And what I'm really going to give is just a brief State of the Union, as it were, about breast tomosynthesis and kind of where we are, how we're using it, and what the literature has to say about it. So just as a little bit of background, and this is certainly not new information probably to anyone on the call. We all know that breast cancer is extremely common, and in the United States it's the most common cancer in women if we exclude skin cancer, and it is the second most common cause of death from cancer in women in the United States. And I think the statistic that we're here probably most commonly is that in the United States, 1 in 8 women will be diagnosed with breast cancer in her lifetime. According to the American Cancer Society, the mortality rate for breast cancer has declined about 2% per year for women over 50 and about 3.2% per year for women under 50 since 1990. And that's roughly the time when screening mammography became widely available and easily accessible to most women in the United States. And I think that most people believe that mammography has certainly helped to reduce breast cancer mortality by about up to 1/3 since that time. But again, as we all know, mammography is not a perfect test. There are limitations really on both sides of the equation, with false negatives or miscancers, and then also with false positives, findings that we see on mammography that do not turn out to be cancer. Mammography can miss up to 20% of breast cancers, and it's often because normal dense tissue will mask an underlying cancer. Approximately 1 in 10 women will be recalled for additional imaging after a screening mammogram, the so-called recall mammogram and/or ultrasound. But in about 10 to 20% of those women, that potential abnormality that we saw on the screening will just turn out to be normal superimposed tissue. And these false positive examinations can be very stressful for our patients, and obviously they increase the cost too, because the patients have to come back and have additional imaging with spot compression and sometimes with ultrasound as well. Full field digital mammography, or FFDM as we term it, has largely replaced film screen mammography in the United States. Even here in New Orleans, Louisiana, which is, obviously kind of a out-of-the-way place a little bit, the last group that was doing film screen mammography switched to digital about 3 years ago. So even in this part of the country, it's virtually 100%. And based on the DMIS trial, we all know that there are some advantages for patients with full field digital mammography over film screen, particularly in younger women, women who are perimenopausal, and then those who have heterogeneously dense or extremely dense breast tissue. And I just make a note, you'll see that there's a reference number at the end here. I have a slide at the end that has the references for all of the various articles I'm going to be discussing. So what is digital breast tomosynthesis? Well, the first vendor in the United States received FDA approval almost exactly 4 years ago, and the indications at that time were basically for the same as what we use regular 2D or planar mammography. It can be performed with planar mammography or alone, and the currently available digital breast tomosynthesis equipment can produce both full field digital and digital breast tomosynthesis images. So basically what I'm saying is it's not two separate machines, but you can't just get a software upgrade to your standard digital mammography unit. It actually requires the purchase of an entirely new piece of equipment that can perform both functions. Let me see here. This is just the two companies, skip the slide there, in the United States, GE and Hologic, that now have FDA approval for tomosynthesis equipment. And although their technologies are slightly different, both products can deliver the combination of planar and tomosynthesis views that are necessary to deliver optimal imaging. So like full-field digital mammography, digital breast tomosynthesis is an X-ray piece of equipment. It uses differences in the way tissue, both normal and abnormal, attenuates X-rays, and that's how it produces an image. When we take a digital breast tomosynthesis study, the patient is in compression, just like for her standard mammogram, but in addition to that exposure, the X-ray tube will sweep in an arc over the patient and take images at multiple angles. I always put this next little bullet point in every talk that I give about digital breast tomosynthesis because there's sometimes some confusion by our patients who hear about this sweeps in an arc and think that they're not going to have compression like they do for a mammogram. But that is unfortunately not true. Just like conventional mammography, you do have to still have compression for all the same reasons that we need it with regular mammography, to stop motion unsharpness, decrease some of the radiation scatter, and also to help us better delineate the anatomy. When we take a digital breast tomosynthesis study in addition to a regular mammogram, it takes about 4 or 5 seconds in compression for the patient to have those extra images. And honestly, from the standpoint of the patient, it really is not that much different. It's just a little bit of extra compression if we do tomosynthesis in addition to regular mammography. So the raw data that we get from tomosynthesis is reconstructed at 1 millimeter intervals throughout the breast tissue. And the way that we look at this is a series of high-resolution slices. And I actually have some of these images at the end of my presentation, just for those who may never have seen them. Well, what that means, though, is that that is a lot of images. So if we do the math, the average patient sort of compresses usually to about 4 centimeters thick, which would be 40 millimeters, and so that's going to be 40 additional images in each projection. Now, there are some patients who are larger and may only compress to about 7 or 8 centimeters, and so in those cases, we may have 70 or 80 additional pictures in each projection. So if you remember, in regular mammograms, we take images in the CC projection, compressing from the top, and then we take them sort of at an angle from the side, or an MLO. So in each one of those projections, we'll have that many additional images. In general, we have to still get those 2D planar mammogram views. In addition to the tomosynthesis images, we can either acquire those directly, so you take your planar image just like you normally do, and then you take the tomosynthesis images. There are some newer units that, again, cost additional money to get those, where from the tomosynthesis images, a 2D or planar image can be reconstructed. And the value of that really is that because tomosynthesis, which is an X-ray test, has additional radiation exposure, if you can reconstruct a planar image, which you still need, from those tomo data sets, that will reduce the radiation exposure somewhat. So what are the advantages of tomosynthesis? Well, it definitely provides a clearer depiction of the anatomy. That issue of the overlapping normal tissue that I had spoken about earlier on is certainly reduced, and in some cases even largely eliminated, by having tomosynthesis in addition to planar mammography. It also makes underlying abnormalities that might be masked by the normal denser tissue more easily perceptible. It also helps us to confirm if superimposed normal glandular tissue does not turn out to be a cancer. One of the other benefits that is perhaps not as well known is that it actually helps us to localize findings in the breast as well. So sometimes we may be in the situation that we only see a finding either in that CC or from the top view, or in the MLO or from the side view, and we don't really know where that is in 3 planes. But with tomosynthesis, because we know, for instance, in the CC view, which slice was the one that was closest to the feet, and then at the other end, which was the closest to the head, if we see something only in 2 views, we'll know, okay, well, that's about 3 centimeters up from the feet. That's probably going to be a little closer to the feet. I can look on my other view, and it might help us to find that. Certainly, if we are doing an initial tomosynthesis study, it is always done with the standard planar images. And we need that, number one, to show us the anatomic distribution of the findings. So we're sort of not off the hook. Because we're going through in those 1 millimeter slices, sometimes you can't really see, say with microcalcifications, that they have a ductal distribution. So that's one very important reason why we still need the planar images. And also, tomosynthesis does not have the capability of doing those, what we call magnification images, with a small focal spot. So we still need those to evaluate microcalcifications and to see the ones that may be too small to see with a standard mammogram. There have been many studies that have confirmed these clinical benefits of digital breast tomosynthesis, and I think one of the most advantageous things about breast tomosynthesis is, as I often say, it bends the curve both ways. It improves both the sensitivity and the specificity of full-field digital mammography. So it means fewer false negatives or missed cancers, but it also means fewer false positives and fewer recalls. So on the next slide, I have just the next 2 slides, really a summary of some of the literature that is out there in support of tomosynthesis. Again, at the end, I have the references for each of these different research studies if you want to go kind of further down into the weeds of all the different the studies themselves. But I basically just have a high-level view here, and this shows basically kind of the 6 largest studies that have been done so far. There are many others, but these are the 6 largest. And you can see they vary in size from 7,000 patients with the STORM trial to over 200,000 patients with Dr. Friedewald's study. And you can then see the design. Some are retrospective, some are prospective. So in the last column over here, I have what has been the relative increase in cancer detection, and the range goes from 3.5% all the way up to 51% for the different studies. Then if we look at the other side, the recall rates or the false positives on each of those studies, you can see that in every instance the recall rate went down. And this is the number of patients who have an abnormal screening but have to come back for additional images. And then finally in the column on the far right over here, I have what the breast cancer detection rate is, which is generally reported per 1,000 mammograms. And you can see as well that in every study, the breast cancer detection rate went up. So basically, as I had said before, this really bends the curve both ways. It helps us detect additional cancers that we would not have seen otherwise, but it doesn't do so by increasing the number of false positives. It actually, at the same time, decreases the number of false positives. So the overall recall rate reduction, if we look at all of those studies put together, was about 28%. I think it's also important to note that for the most part, the increase in cancer detection was not simply additional non-invasive cancers, but rather tended to be invasive cancers, which are obviously the ones that are most concerning and can eventually metastasize. And there was actually a 35 to 41% increase in detection of invasive cancers if we look at the 3 studies where they actually pulled out the invasive cancers and didn't just report non-invasive and invasive. One other important statistic, and this was not measured in every one of the studies, but is another, I think, very important positive about breast tomosynthesis, is that the positive predictive value for the biopsies went up an average of about 21%, and that's the BI-RADS category 4 and 5 lesions that then go on to have, usually nowadays in the United States, percutaneous biopsies. But again, fewer patients having unnecessary procedures, fewer false positives. There is also some literature support to suggest that the benefit may be greater in patients with denser breast tissues. So for instance, there's one study that shows that there was an increased cancer detection rate in patients who had BI-RADS category 2, 3, and 4, with a 30% relative increase in overall cancer detection rate and a 40% relative increase in invasive cancer detection rate. And then two other studies demonstrated that although there was a reduction in recall rate or false positives in patients with both fatty and dense breast tissue, that reduction may have been slightly greater in the patients with dense breast tissue, and so they may see a greater benefit. And I think that's particularly important because it is those patients with the denser breast tissue who really are the ones where we see that the sensitivity of mammography overall is not as good as in those with fatty tissue. So there is starting to be as well some cost-effectiveness research being done on digital breast tomosynthesis. So we've talked about the clinical improvements that we have seen as a result of the technology, but as I said, we're beginning to see some research that shows that it may have advantages from a cost-effectiveness standpoint as well. So one study in particular came out very recently, showed that there was about a $54,000 per quality-adjusted life year expenditure if digital breast tomosynthesis was added to biennial screening full-field digital mammography in women 50 to 74. That's about, not quite, but close to 50% less than the accepted threshold of $100,000 per quality-adjusted life year that the authors used as a comparison. And basically what they found was that in 1,000 women after 12 rounds of screening, there were 405 fewer false positive findings and 1/2 of a breast cancer death reduction. So basically more like one breast cancer death reduction that was averted in every 2,000 women, because obviously half a person can't die. And then a different study looked at the financial impact of adding breast tomosynthesis to yearly screening mammography in women 40 to 75 in a hypothetical managed care plan of U.S. patients with 1 million members. And what they found, and this was obviously done with mathematical modeling, was that despite an initial extra cost for digital breast tomosynthesis, so as I had talked about earlier, you do have to buy new equipment, and in some cases you actually have to buy new workstations to read these on because not all of the PACS vendors have a way to view these images. There was a savings of $2.4 million a year due to the reduced recalls and follow-up procedures, and that potentially, if this were applied to the 19 million mammograms performed each year in the United States, the savings could be as much as $550 million. One other thing, just from the standpoint of what the initial sort of expenditures are with breast tomosynthesis, the images are very large. There's a lot of data. So for instance, in my practice, we actually had to purchase additional PACS cache, C-A-C-H-E, in order to implement tomosynthesis. The CPT codes, which were just approved this year, are on the slide that you see before you. We all know that the G codes for the full-field digital mammography are the G0202, 0204, 0206 series. We presented at the CPT editorial panel and then at the RUC codes, two of which were for diagnostic digital breast tomosynthesis and one of which was for screening. The screening code was an add-on code because, as I had said before, right now we always perform, and you really must perform, those standard planar images in addition to the digital breast tomosynthesis. So in the screening arena, it is always going to be planar images plus digital breast tomosynthesis. So that was the only proposal that we had made. Now, for the diagnostic codes, we had originally proposed standalone codes, thinking about, for instance, cases where we might see an abnormality on a planar mammogram, but might not need to repeat the planar images and only do the tomosynthesis. What was approved by CMS was a slightly different model in which both the screening examination and then with an additional newly created G code, the diagnostic examination was as an add-on to the planar mammography. So I believe what I have next is just a slide. This was sent to me recently that called Time Magazine, one of the 11 remarkable health advances for 2014 was digital breast tomosynthesis. So it's always nice to have some lay press that gives you some acclaim. And then I believe what I have next are just some clinical cases. So on the left, you see just a regular 2D mammographic image, and then I have one slice from the tomosynthesis where you can see this area of architectural distortion, which really kind of leaps out at you on the tomosynthesis image, was very hard to detect on just the planar images. The next slide has the same case, but looked at in the other projection. So the first slide was that CC from above view, and this is the MLO sort of from the side at an angle. And again, hard to perceive, but much easier to find on the tomosynthesis. On the next slide, I actually have a cine loop. You can see it moving very slowly, and I'm going to point out where the cancer is. It's going to cycle through again, and it's right there. I don't have a way to stop it, and I only have 2 of these cine loops in here from all the images because they're such large files that it's very hard to put them into a presentation like this. But as you see, as we step through right there, you can see where that area of architectural distortion is that turned out to be a small mixed ductal and lobular invasive carcinoma. The next case that I have, another patient who was recalled from screening, very dense breast, one of those that really gives us fits, and then on our these are actually spot compression tomosynthesis individual images, and it's apparent that there's actually a quite large cancer here that has some calcifications and significant architectural distortion where we can really see that tissue being pulled in. And again, in this case, I have a tomosynthesis cine loop, and you'll start to see the cancer come in right about there, and it's going to go through again. I'm sorry, it's jumping a little bit, but it's going to go through again, and there it is right there, much more easily seen on the tomosynthesis images. And this turned out to be a large invasive ductal carcinoma with some ductal carcinoma in situ as well. The next case is a smaller invasive ductal carcinoma. Again, very hard to pick up here on our standard planar mammographic image, but we can see all of the tissue being pulled together here on the tomosynthesis image. And I have another case after this. This is a larger cancer, and I'm not sure if the benefits in this case are necessarily because we wouldn't have perceived this cancer, but by having this tomographic slice here, you can be very certain that there is an abnormality there. And that's the CC, or from the top view. Here is the side MLO view in the same case. And this is so clearly defined that you really don't need to do spot compression or additional images. You can often, in a case like this, just go straight to ultrasound, saving the patient some radiation, additional discomfort from having those additional mammographic images. Next, this is just another small invasive ductal carcinoma, better seen on the tomosynthesis slices. And I think, too, this case demonstrates one of the benefits in that even if one were to do an ultrasound on this case and not see any abnormality, this is a small cancer in a relatively fatty breast, it might be difficult to find with ultrasound. I don't think that anyone would be dissuaded from the fact that there is a mass there and not biopsy this. And I think I should point out, too, that there are ways to biopsy lesions that are only seen with tomosynthesis guidance. So you can use the machine for that as well. This was another small invasive duct cancer, very difficult and low density, even on the spot compression images. But clearly, again, there was absolutely an underlying mass there. There was no question about it, whether we saw that on ultrasound or not. And then finally, I think I have one more case. Yes. Yeah, these are 2 images from the same case. This is a patient who was recalled for this finding, and then we did additional images. We did a combination spot compression and tomosynthesis image. And again, this really doesn't stand out that much, but on the tomosynthesis image, it's obvious that there is a mass right there, and this turned out to be a mucinous or colloid carcinoma. And again, very hard to pick it up here on the standard mammographic image, but quite obvious on the tomosynthesis slice. And I think my next slide is just a summary for everyone. So it's been about 4 years since the FDA approved digital breast tomosynthesis. There have been multiple studies that have demonstrated that adding digital breast tomosynthesis to full-field digital mammography improves the clinical performance if we compare to simply digital mammography alone. There's a decrease in the recall rate from about 8.7 to 12% for digital mammography alone to 5.5 to 9.1% for the combination. At the same time, an increase in cancer detection rate from about 4.04 to 6.4 per thousand examinations up to 5.3 to 8 per thousand for the combination. And the hope is that by improving both of these two things, the decrease in the recall rate and the cancer detection rate, we will be able to not only detect more cancers, more invasive cancers, but also reduce patient anxiety from having to have unnecessary testing, including in some cases biopsies, and potentially lower the costs. And I think that my next slide is just the references. Okay.
Okay, thank you so much. I am going to look here to see if we can, if we have questions. Let's see. If you have a question, you can use the raise your hand feature, or you can type your question into the question box that you should see on your screen. Don't see any hands. Oh, I do see hand raised. Vicki Combs, your line should be unmuted. Is there a Vicki Combs? You might need to unmute your line on your end as well. It says here that your line is self-muted. If anybody else has questions, please use the raise your hand feature or type your question. I do have some questions typed in here. I'm just trying to figure out how to make it a little bit bigger so I can see it. I have folks asking for copies of the slides. Dr. Smetherman, are you okay with handing out copies of the slides?
Absolutely.
Here's another question that we got. In the statistics for recall rates, do you take into consideration callbacks for ultrasound only?
In those studies, it is not dissected out, but at least at RSNA, I think it was year before last, there was a presentation about the number of times, and I can't remember what it was, but that patients were able to simply go straight to ultrasound, which is usually pretty uncommon if you're recalling someone for an asymmetry or what could be a mass. In general, most people using just standard full-field digital mammography will do spot compression images first. So there is some literature about that, but I don't actually have that reference. And in those studies that are there, I do not believe that they did.
Okay. And I did have a request to go back to the coding slide, so I'm going there. And then a question was, has there been discussion regarding G-code reimbursements for digital breast tomosynthesis? Our radiologists take much longer to interpret tomo than digital mammography. And Geraldine, I don't know if you want to take that question.
Sure. Can you hear me?
Yes, I can.
Can you hear me, Katie? Okay.
Yeah.
So the first part of the question was about have there been questions about G-code reimbursement? And yes, you know, our members have had a lot of questions for us about the Medicare coding structure, but also a lot of questions about the fact that many private payers appear to still be considering this as an experimental technology. So what we've tried to do at the ACR is provide guidance around the coding structure that you see here for Medicare. One of the things that to which Dana alluded was the idea that we felt that it was potentially possible to do a diagnostic digital breast tomosynthesis as a standalone study, but the way CMS has crafted the coding structure, it always has to be done as an add-on. So that was prompted a lot of questions from members. But again, as they're now starting to see patients coming in, Medicare patients where this is covered, and then having to say to some of their commercially insured patients, well, it's not covered because it's considered experimental by your insurer. Obviously, our members are asking us for guidance, and we've certainly tried to be as clear as we can that we feel that this technology is ready for prime time. As Dana has very clearly outlined, it has proven benefits to our patients, and certainly one which we think should be covered.
Okay. The NCCI National Correct Coding has bundled CAD 77052 with the new TOMO code 77063. This bundle cannot be broken. Thoughts?
Dana, I'm happy to take this unless you'd prefer to.
No, I know this is you're welcome to take this. It's certainly a topic of active discussion at the ACR.
Yes, so we believe this is an absolute error by the agency. First of all, CAD can't be done with tomosynthesis. It's only done with the planar mammography. They're two different ways of examining or evaluating the breast. Each has their benefits. It's like saying you can't bill a mammogram and an ultrasound together. So we have strongly protested to the agency that we do not feel that this is an appropriate edit.
Yes, our hope is that perhaps this is an error, but it's actively being addressed.
So please stay tuned for more information from the ACR on that one. Next question, what is the Medicare code for the diagnostic workup mammogram with TOMO?
Well, it's going to be either the GO204 or GO206 with the GO279, which is what's on the slide there. That's if it's done with a diagnostic full-field digital mammogram with tomosynthesis as well.
The next question, are insurance companies reimbursing for this procedure or considering it experimental? And as staff for the Managed Care Committee, I can say that it's a little bit of both. Dr. Smetherman, do you have anything to add to that?
No, I mean, I think that we are all, as we go through this January, finding out exactly for ourselves in our own practices and watching very carefully to see where it is and where it is not. Our hope is that in the next few months, more and more of the payers will adopt it. I think that, originally there was perhaps a little bit of lack of clarity about whether this was investigational or not, but obviously we wouldn't have taken it through the whole CPT and RUC Category 1 process if we didn't feel like the literature support was there. You have to have a fair amount of literature support. So basically all the things that I presented in my talk.
And also to add, we do have several payers on the line, I believe, and certainly if you have further questions, we're happy to engage you in a discussion. Just contact me, Katie Kaiser, for that. And certainly any members who are on the phone that are having difficulty with reimbursement, feel free to share the recording. I'll send out the link to the recording for this webinar to payers or refer them to us as well. More questions about slides and a couple of repeat questions here on the coding and coverage. Does ACR have handouts for patients to support reimbursement and provide documentation to the payers?
That is a great question. We've definitely issued guidance for our members. I don't believe we've issued patient-focused literature, but we'll certainly take that on board and get it out there.
Yeah, sounds like a great idea.
Is CAD reimbursable when using 3D Tomo?
Well, right now Medicare is saying it's not by virtue of the edit that was just described, but obviously we're hoping that that will be overturned.
Okay. With the add-on of the Tomo codes, are we required to change our authorizations if Tomo is standard of care at our facility?
That's a great question, and we've had that question and gotten a consensus opinion and believe that it does not require a separate order.
I think there was some published guidance about that too, maybe a Q&A.
And just in reference to the question above about the patient literature, I have a note here that Hologic provides literature supporting reimbursement.
Okay.
And then another question, should we stop billing CAD with 2D and 3D for Medicare patients then, since there's an edit in place?
That's a good question. I believe that the edit will supersede the billing. You know, obviously we're optimistic that that edit will get turned over, so I suppose we wouldn't want anybody to completely rework their payment algorithm so that they didn't turn it back on. But you know, I would say if someone does feel more comfortable turning that off, that they should follow our website closely, so that if the edit does get overturned, they can turn it back on.
Okay, are there any further questions? Either type them into the question box or raise your hand. And I do still show Vicki Combs with her hand up. I did unmute your line. If you unmute the line on your end, you should be able to speak. One more question here. Does Tomo require a physician order?
So again, we have taken the position that it does not require a separate order.
Okay, I'm not showing any more questions. I want to thank everybody for attending today. Thank you so much to Dr. Smetherman and Dr. McGinty for taking their time today to do this webinar with us. Again, if you have any follow-up questions, please send them to me, Kay Keysor, that's 2 K's, E-Y-S-O-R, @acr.org. I can get your questions to Dr. Smetherman or Dr. McGinty. And also, I will be sending out a link to the recording, and we do urge you to share the link with payer contacts if you're a member. If you're a payer and you have additional questions, please do contact me, and we'd be happy to engage you in a dialogue. Thank you so
Casey,
much.
I would just like to add my thanks to Dana for an excellent presentation, and also to thank everybody who's joined the webinar this afternoon, and again to reiterate that if there are follow-up questions, we'll be delighted to answer them if you'll reach out to us.
Absolutely, and you are all very welcome. Thank you for your time.
Thank you. Have a great day, everyone.
You too. Bye.